Good afternoon, everybody. It's time to start. So welcome to the shoulder session. So we will be talking about rotator cuff tendinopathies. Just before we start, don't forget to put your cell phone on the silent mode. So the symposia today will be 90 minutes. I will start, by the way, my name is Jean-Sébastien Roy. I'm the chair of this session. So I will start with an introduction and a small presentation. Then I will be followed by four presenters that they will each present for 15 minutes. And then hopefully we will have a 15 to 20 minutes period for questions. So prepare your question, we will need it. So it can be question, can be discussion, anything you want. Just if you feel free to discuss shoulder with us. And then if we have time, a small conclusion. So who are we? I'm lucky to have four well-renowned shoulder researchers. So we have with us Laurie Michener from the US, from the University of Southern California. And Laurie is interested in the mechanism and the diagnosis and treatment of orthopedic and sport injury of the shoulder. We also have two researchers from Belgium. We have Anne Koels from Ghent University. And Anne is her research lies in looking at scapular involvement in shoulder pain. We also have Philippe Strouf. I just learned how to pronounce his name. I'm not sure I'm right. So he's from the University of Antwerp, and he's interested in chronic shoulder pain assessment and rehabilitation. We have Gisela Soul from New Zealand at the University of Otago, and she's looking at the use of a neuroscience approach for management of subacromial pain. And finally, I'm Jean-Sébastien Roy. I'm from Quebec City, Canada at l'Université Laval University. And I'm looking at defining central and peripheral factors associated with chronic rotator cuff tendinopathy. So these are the learning objectives of our session. So what do we mean by rotator cuff tendinopathy? Some of you might know that there's many synonyms for this disorder. Some call it tendinitis, tendinosis, bursitis, shoulder impingement, rotator cuff related shoulder pain, subacromial pain syndrome. So what we mean here during the session is shoulder pain caused mainly by subacromial structures, such as the cuff tendons, the bursa, and the long head of the bicep tendon. So why should we care about rotator cuff tendinopathies? A big problem with rotator cuff tendinopathies is that they often become chronic. If we look at data from Europe, it shows that 40 to 50% of patients reports persistent pain and disability 6 to 12 months after initially consulting their physician. So they often become chronic. It leads to high costs for health services, insurers, and society. Data from Canada shows that shoulder pain and rotator cuff tendinopathy involve almost 24% more days off work than other types of MSK injuries, such as low back pain. So the average for a shoulder pain, the average number of days of work is 119 days for shoulder pain compared to 87 days for low back pain. So chronic rotator cuff tendinopathy can lead to seriously impact quality of life and lead to early retirement. Therefore, it is essential to better understand the factor associated with the development and chronicity of cuff tendinopathy, and to develop effective strategy to overcome the burden of cuff tendinopathy. So that's why today we have a session on chronic tendinopathy. So as the chronification of rotator cuff tendinopathy is likely complex and multifactorial, we will be looking at 5 factors today that may have a role in the chronification of rotator cuff tendinopathy. So I will briefly talk about central nervous system reorganization following shoulder disorders. I will be followed by Laurie Mischner, who will talk about the tendon involvement in rotator cuff tendinopathy. Then Anne will talk about the scapular involvement. Gisela will talk about shoulder proprioception and rotator cuff tendinopathy. And finally, Philippe will finish with central sensitization at the shoulder. So I will start with central nervous system reorganization. Maybe 10 years ago, most of the rehabilitation approaches for the shoulder were mainly looking at the deficit at the joint level. So we were looking at mobility, strength, posture. And studies have shown that these structural dysfunction approaches are effective for some MSK population, especially in acute presentation. However, they have limited effectiveness for chronic MSK pain. One of the reasons that might explain this limited effectiveness is that the central nervous system can undergo plastic reorganization following MSK disorders. And these reorganizations can be maladaptive and lead to altered joint control and eventually to chronic pain. There's two main reasons why looking at peripheral structural dysfunction may not be sufficient. First, sometimes there's a failure to recognize the complexity of pain by focusing only on the nociceptive signal arising from the peripheral receptors. We all know that there's a very poor association between symptoms related to MSK disorder and structural failure, especially at the shoulder. We know that there's a lot of people who have asymptomatic structural changes at the tendon or the bursa, and they don't have any pain. So there's a very poor association. And sometimes disparity in the pain level can be explained by central sensitization that will be discussed later by Philippe. Another reason might be that we might neglect the fact that the brain can rapidly adapt to changes occurring in the periphery. In fact, brain reorganization have been documented in numerous MSK populations, and we have shown maybe 3 or 4 years ago that in people with rotator cuff tendinopathy, there is a decreased cortical spinal stability for the affected shoulder when we compare to the non-impaired shoulder. And in fact, this reorganization was more important with more chronic. So there was a correlation between symptom duration and the change in the cortical spinal stability. In other MSK population, other type of reorganization have also been shown, such as overlap in the spatial territory of cortical representation of muscle and shoulder pain, and elbow pain, changes in the spatial territory of M1 representation in low back pain, and alteration in intracortical, inhibitory, and facilitatory networks in elbow pain and low back pain. So these brain reorganization may disrupt the facilitation of muscle needed to realize a motor task, the inhibition of other muscles that are needed for the fine-tuning of a movement, and altered intermuscular coordination. And they might predispose people with tendinopathy to modify their motor strategy to control the joint that could in turn contribute to chronicity through maladaptive plasticity. The good news is it is possible to reverse the maladaptive reorganization of the brain, as the brain has the capacity for adaptive plasticity. And several studies have shown that it is possible to reverse the brain organization following surgical or rehabilitation intervention. Therefore, brain reorganization should be one of the main targets during rehabilitation of chronic tendinopathy. That's why in our research we try to consider both the central and peripheral deficits. This is an example of the type of approach that we use in our lab to look at the effectiveness of different rehabilitation intervention. So we look at the joint deficit, so we look at mobility, strength, posture, but we also, and we treat these joint deficit, but we also try to educate on motor control, educate on pain neuroscience, educate also on graded exposure to exercises. We use a lot of sensory motor training to improve shoulder control. We use feedback to make sure they are aware of their limitation or their compensation that they use. We put a lot of emphasis on quality of movement, and we gradually increase the difficulty of the exercises performed at the shoulder to make sure that they are confident in using their shoulder. And we try also to build self-efficacy to make sure that they are able to self-manage their symptom, again by using education and by using feedback to make sure that they enhance their error detection capabilities. There are also new therapies that are emerging that are said to induce plasticity and normalize brain organization. They are said to modulate neuronal membrane potential and neuronal stability. These new emerging therapy include non-invasive brain stimulation, such as TDCS or transcranial direct current stimulation, and different type of peripheral neuromuscular stimulations. In fact, we have looked at the added effect of TDCS. In fact, the objective of the project was to compare a group receiving a rehabilitation program center on sensory motor training combined with anodal TDCS to a group receiving the same program with sham TDCS, just to look at the added effect of TDCS on learning. We use a triple-blind RCT with two groups of 20 subjects. The two groups had the same intervention for 6 weeks, and they were evaluated with a DASH and WORC two questionnaire for the shoulder at 3 weeks, 6 weeks, and it's written 12 months, but it's 12 weeks. And the rehabilitation program that we used was similar to what I just mentioned, but like 70% of the time with the patient, we use sensory motor training and a graded exposure to improve shoulder control. And during sensory motor training, we use TDCS only during the first 5 sessions. And what we found is that TDCS did not lead to more improvement. So you can see the dash above and the dash below and the WORC above. So the WORC, we want to reach 100, which is a normal function, the dash 0, which is a normal function, and we can see that the two groups were similar. So we did not find any added effect of using TDCS with this group. And there's two things. TDCS did not add anything, but also the intervention was very effective because after 12 weeks, they were below 10 on the dash, which is a very good result for the dash. So in conclusion, chronic cuff tendinopathy may not be confined to the joint as one thought, and this may be explained by maladaptive brain reorganization. And I think it is necessary for clinicians to improve their understanding of the central neural mechanism that might lead to motor deficit and pain in order to tailor intervention that could optimize recovery and prevent chronicity. As for new emerging therapies, I think more studies are needed to show that they are superior with the conventional approaches that we use in clinic. So that's my part, and Laurie will follow me. Laurie.
Thank you for that great introduction to chronic rotator cuff disorders. So my objectives today are to talk about rotator cuff tendinopathy with respect to mechanism and diagnosis. So let me give you the conclusions up front of the things we'll discuss in the next 15 minutes or so. Rotator cuff tendinopathy is a heterogeneous pathology. It runs from subacromial pain, and we'll talk about defining that, the whole way to a full thickness rotator cuff tear. The question becomes, as physical therapists, do we treat these patients who have the whole gamut the same, or can we argue that they likely have different treatments and also different prognosis? And we'll talk about that. The two predominant mechanisms we think about with respect to the tendon are compression and overload to the tendon. Up until probably about 15 years ago, the predominant thought was it was impingement and overload, similarly, but a heavier emphasis on impingement. As we've moved away from this, we continue to question whether or not impingement is likely or not, and we'll talk about some evidence that indicates it can occur, but maybe not in the range of motion that we thought. There are intrinsic, extrinsic factors, and other factors, such as personal and societal factors, that can influence our rehabilitation and drive our treatment decision-making. My focus will be on the intrinsics today. And then finally, I'll talk about diagnosis in the clinic. What's the rehabilitation diagnosis to help drive clinical decision-making, and how do we use special tests to do that? And some may not be as good as we think when we look at systematic review meta-analysis. So rotator cuff tendinopathy, they're partial thickness to full thickness tears to just tendon changes that aren't full or partial tears. Tendinopathy, there's some change within the tendon, but there's no disruption of the fibers. Versus a partial thickness tear, and it may be any part of the tendon from the articular side to the bursal side, and this demonstration on the picture there is on the bursal side, or a mid-substance tear. And full thickness tears, there's a complete rupture from top to bottom of the tendon, but not necessarily side to side of the entire common tendon that occurs on the greater tuberosity of the supra-infra teres minor, for example. And you can consider it as there's a hole in the sock somewhere, there's a tear, but it doesn't necessarily go across the entire tendon unless it's a 3-tendon tear. That's important to remember with full thickness tears as we think about them, because there's still something intact. It's not the complete tendon ruptured of all 3 tendons in most patients. So when we think about this from a clinical diagnosis, we have the pathology going from full thickness tears down to subacromial impingement or tendon without tears to a partial thickness tear. They're all considered tendon pathology, but we like to think of them as the partial thickness to impingement likely as a single clinical diagnosis driving rehabilitation decision making, and we might enable this subacromial pain syndrome I'll talk about in a second. Versus we differentially diagnose full thickness tears because likely, even though they may get very similar treatment, the full thickness tears likely have a different prognosis than patients with these partial thickness or just tendinopathy. And so we split them up with our rehab decision making. So subacromial pain syndrome is the phrase that some people have started to use to replace subacromial impingement. Why might that be? Impingement implies that there is compression as the primary or only mechanism that's causing the tendon to be injured. Given that, we know in evidence that we'll talk about in a bit that compression is not the only mechanism. Using the word impingement in the title really can perpetuate flawed reasoning, meaning if our thought is that it's impingement, then we must do something to open that space in order to make them better. Opening the space to a surgeon means I should go on and shave some things off and they should feel better. And in clinical trials that we'll go over, that doesn't actually hold true. So calling an impingement really might perpetuate this flawed reasoning that opening the space is the primary thing we want to do, when indeed that isn't the case. So I was fortunate enough to be asked by Anne to write a commentary about shoulder pain with respect to this subacromial rotator cuff tendinopathy, rotator cuff disease. What do we call this? We mostly might agree that impingement shouldn't be called for all of rotator cuff disease because it's not the only mechanism, but there's other potential times when impingement is the mechanism and it should be called that. So subacromial pain syndrome might replace the title in my mind of what I use, but you might see it called rotator cuff related shoulder pain. Some people really may still call it tendinopathy or disease because there's something wrong with the tendon, but we're not implying a mechanism. So unfortunately, in our world of rotator cuff, it's called lots of things. So talking a bit about the impingement syndrome, 2 predominant theories that there's this mechanical compression. So as I raise my arm, the humerus gets closer to the coracoacromial arch and the tendon gets impinged. We imply that as they get to 90 or above, they have this pain, and therefore compression is likely what's causing that pain to occur in and around maybe 60 as their arm moves overhead to 120 in that painful arc. The other less predominant mechanism was overload and degeneration of the tendon. Not that they occur separately, because as you get compressed, the tendon would degenerate. But realistically, we kind of took the tendon overload and degeneration in more recent time, thinking this may be a more predominant mechanism than we thought. If mechanical compression was the predominant mechanism, then in randomized clinical trials from starting back in 1993 for both short and long-term follow-up up until 2013, we see that if we randomize people to physical therapy, conservative management, versus surgical management, acromioplasty, patients don't get better with the acromioplasty any better than people with rehabilitation. So if impingement was the predominant mechanism, we should see that people who had surgery to open the space should get better. So bony pathology is likely not the only mechanism that occur, and so using impingement in that title may not appropriately or would inappropriately perpetuate the flawed reasoning for treatments. So there are lots of factors to consider with subacromial pain. Intrinsic factors are what I'm going to talk about. There's extrinsic factors that the rest of the panel and also Jean-Sébastien Roy have already talked about with respect to some brain CNS aspects. We infer that this can lead to impingement, so the middle aspect, that the subacromial space can get smaller. There might be impingement leading to this rotator cuff disease or tendinopathy. But on the sides, you can see intrinsic mechanisms or extrinsic mechanisms may lead to increased load on that tendon, leading to rotator cuff disease absent of that impingement. So tendon overload. Neovascularization. In the lower extremity, people have studied neovascularization in the Achilles, in the patellar tendon. Predominantly, it's the two major areas. Finding that when there's increased blood supply, increased vascularization in the tendon, that it was associated with increased pain in that structure. In the shoulder, it's much less commonly studied for two reasons: less vascularity in the shoulder supraspinatus tendon initially, and also it's harder to image the tendon than it is the Achilles and the patella. But in two studies, in an earlier study, Jeremy Lewis of the UK found that there was increased neovascularization in the supraspinatus tendon. In a subsequent study by Joe Cardoni, found that there was no more prevalence of neovascularization in people with shoulder pain. So we're left with equivocal findings. Is vascularization one mechanism? And it seems that we don't really have that clear-cut answer. There's also tendon degeneration with overload. In some nice systematic review by Ben Dean, inflammation is present in some form in some patients with shoulder pain. We think of tendon and we think of not calling it tendinitis because inflammation isn't always necessarily there, and in fact some tendinitises, or in some tendon disease, in the lower extremity for example, there is no inflammation. But we do find it in shoulder, and so inflammation may play a role with the tendon changes. There's also abnormal collagen laydown, and the tendon differs as it crosses pathology, as it goes from acute to chronic or more overloaded over time. So initially, we see in a couple studies that the tendon has gotten thicker when initially the disease process starts. Achilles tendon shows very similar response. The tendon gets thicker. Interestingly enough, though, as we continue to use the shoulder and disease progresses, the tendon starts to thin and eventually starts to disrupt and tear. In the lower extremity, the Achilles, the tendon thickens and typically stays thicker. So the shoulder tendons don't necessarily act like other tendons, for example, that we compare them to. We also see that tendon thickens with use, so it's a normal response, potentially, the tendon, that we can actually detect. And we've seen this in a couple studies, that with overhead athletes, the tendon's a bit thicker, or spinal cord injury patients as well. So is compression in the outlet then allowed? So if the tendon's thicker, at least acutely, does it's within that space actually lead to mechanistically compression? So measuring subacromial space multiple ways, and in this instance I'm going to talk about ultrasound measures. So imaging the shoulder with ultrasound And we can see then on this image, if I can bring this up, this is the acromion up here at the top, and down here at the bottom then is the humeral head. And we measure the linear distance of the acromiohumeral distance to capture one aspect of the subacromial space. Obviously, it's a single measure and not a three-dimensional measure. The acromiohumeral distance is about 10 to 15 millimeters in healthy individuals. So again, reviewing the tendons thicker initially with disease and overuse. What we know in subacromial space linear measures, the subacromial space is smaller in those with quote-unquote impingement or subacromial pain. The question is it small enough to cause impingement? The space gets smaller, the tendon gets thicker, but still, is there enough room for the tendon to move without compressing? Our group at USC, and prior to this at Virginia Commonwealth University, have looked at how much the tendon occupies the subacromial space to try to understand if compression is possible. And we found that in people with impingement, the tendon occupied greater amount of space than in people who had healthy shoulders. We've also seen the same response in spinal cord injury patients who have overuse of their shoulder, and in overhead athletes as well, but not necessarily with shoulder pain in the spinal cord injury. So is compression possible? So in a cadaveric example, we know that compression is possible, but in vivo, when we start to look at patients, can we sort out if compression is possible? A lot of studies have looked at the relationship between the acromion and the humeral head. The problem is it's looking at bone and not the soft tissue. So as my humerus moves closer to my acromion as I raise my arm, the space gets smaller, yes, that's clear, that happens. But is it small enough that compression occurs? In a recent paper coming out in the Journal of Orthopedic Research, a group out of Paul Ludwig's group and her doctoral student Rebecca Lawrence have looked at some modeling studies and been able to model soft tissue as well, and see that the smallest acromiohumeral distance is in this 0 to 90 degree, from anywhere from 0 to 90 degrees of elevation. And it seems to be small enough that compression is possible. The tendon is available for compression from 0 to 70 degrees. That's a critical point. So the group out of University of Minnesota found as 0 to 90 degrees, the subacromial space gets smaller, but above that, the greater tuberosity has moved medial to the acromion, so it's no longer allowing that tendon to be compressed because the tendon has now moved medial to the acromion and is no longer available for compression. In earlier work by 3 papers here, they also showed the same thing. As they elevate, and they just looked at this with bony anatomy, as they elevate, the acromion is now lateral to the tendon and no longer available to compress the tendon. So I think the key take-home point is when people get pain above that 90 degrees, it likely, very likely, is not compression, because really compression can only occur somewhere below 90 degrees. Why do they have pain above 90 degrees? That's likely another reason. So both compression and degeneration are causes. We're just less clear about the frequency that impingement can occur and how frequent and how much compression the tendon occurs. So evidence for diagnosis, the last piece. I split them to 2 categories. If I was talking to a group of orthopedic surgeons, they wouldn't stand for this conversation because they want to know the pathology and the entire range of pathology, because they're going to make different surgical decisions from partial thickness tear to just tendinopathy to full thickness. But for a rehabilitation standpoint, I would argue that knowing if they have subacromial pain from a partial thickness to tendon change to full thickness is likely how we drive treatment decision making. So I split the tests into those that are good to rule out are ones that have sensitivity greater or equal to 80% and likelihood ratio less than 0.5, a negative likelihood ratio. For those that are good to likely confirm are those that have a specificity greater than 80% and a positive likelihood ratio and/or a positive likelihood ratio greater or equal to 2. So this is just a summary from multiple systematic reviews. Those that are likely good to confirm this subacromial pain. is a painful arc. Resisted external rotation, there's pain or weakness, but clear that the weakness cannot be really marked weakness. It's just minimal weakness. A full can test, so the thumbs up and you're resisting elevation, and a drop arm test. It's interesting, from these systematic reviews, I think of drop arm for a full thickness tear, but they have some diagnostic ability in these patients with subacromial pain. To screen out or rule out patients with subacromial pain, likely a negative painful arc, a negative resisted external rotation test. This is a Hawkins test, a negative Hawkins, a negative near test, a negative full can, and a negative empty can. I just want to point out one thing. I think about Hawkins and near tests as tests that tell me they have impingement, but those tests over multiple studies have shown they're not good as an individual test to confirm the presence of this disorder, but likely are helpful when they're negative as an individual test to say they don't have the problem. If we look at combinations of tests, though, interestingly, as likely we diagnose, we have combinations of tests. The likely combination now, Hawkins and near, does reappear, but it's only when they're used in combination. Hawkins, painful arc, and resisted external rotation may be the test cluster that's most helpful to confirm and rule out, as long as all three are positive or all three are negative. A less helpful one, I can say that, that's my paper there, less helpful because the positive likelihood ratio is 3 as opposed to a much higher one that Park et al. Had found. So 3 of the 5 might be somewhat helpful, and then less than 3 out of 5 is probably just as helpful as the test combination for 3. Finally, the diagnosis for full thickness tears. Painful arc again, that resisted external rotation, but the key is it has to be marked weakness with external rotation. They have to be fairly weak. Drop arm test, so it's positive for both. External rotation lag test, I put them into external rotation, they lag forward, but that's likely only with massive tears. Atrophy of the infraspinatus, a positive internal rotation or liftoff test with subscapularis tears, the internal rotation, and the belly off test for subscapularis as well. To rule out, resisted external rotation is negative, lag and liftoff are negative, full can and empty can are both negative. And I put this in red, the history, because with full thickness tears, history is an important diagnostic finding. People that are greater than 60 to 65 and complain of night pain tend to be good for confirming. So combinations of tests then, this 65 years old, they have marked weakness with external rotation and night pain, might be helpful as a combination. Test combination from the same group of earlier with subacromial pain, they showed a drop arm, painful arc, and resisted external rotation with marked weakness, helpful to rule in and rule out. Our next speakers then will talk about different combinations of extrinsic factors to talk about subacromial pain. Thank you. I'd like to introduce our next speaker then, Ann Kuhls from Ghent University, to talk about scapula as an extrinsic factor.
Thank you very much, Laurie. Good evening, good afternoon, sorry. Everyone, welcome to this symposium. I'm very happy that I'm here, and I hope you are happy too. So I want to start by thanking my co-presenters, in particular Jean-Sébastien, for taking the initiative for this symposium. So it is my purpose to talk about the role of the scapula in the rehabilitation of rotator cuff tendinopathy, and this is a rather clinical talk, and I hope it will be beneficial for the many clinicians amongst us, but of course it is based on scientific data, so I would like to start to thank again my whole team of the upper limb research team of the Ghent University, because most of the part of the results that I can present today is thanks to their studies. So in spite of the fact that there is no consensus in the cause-consequence relationship between rotator cuff-related or impingement-related shoulder pain on one hand and scapular dyskinesis on the other hand, there are some facts that we need to consider. First of all, we know that a lot of patients with shoulder pain have scapular malpositioning that can change the glenohumeral kinematics. And that has been confirmed by many studies, that the scapula has very often a wrong position or a wrong movement pattern. And because of that, the glenohumeral kinematics may change. Secondly, the rotator cuff may be overloaded in an attempt to maintain the glenohumeral stability, because we know from some recent EMG studies that the activity of the rotator cuff is direction-based and is supposed to maintain stability of the scapula. And then, regardless of the relationship between shoulder pain and scapular dyskinesis, we also know from a functional perspective that the scapula plays an important role in the kinetic chain, transferring energy from the trunk into the arm in daily activities as well as in sports. So having said that, we know that scapular rehabilitation is considered to be an essential component of the treatment of rotator cuff-related shoulder pain. So when we prescribe our exercises, we use many criteria to do so in order to determine which exercises we want to choose or rather not to choose. And one of the criteria is the effectiveness of specific programs as published in literature. Secondly, we look at the patient's expectations and demands. What is the patient want to do with his shoulder? Of course, we look at tissue irritability, making a great distinction in our treatment choice based on high or low irritability. And finally, we can also choose our exercises based on the assumed muscle activity levels of the muscles we want to target during the exercise. And this will be the main topic of my talk today. So when we look about scapular muscle dysfunction in relation to shoulder pain, based on clinical assumptions as well as research, some muscles are supposed to be hypoactive or weak or slow, whereas others are supposed to be hyperactive or relatively too strong. So we know for many years and many studies that very often the lower trapezius and the middle trapezius, as well as the serratus anterior, one of the main prime movers of the scapula, they are very often weak, hypoactive, or not activated quickly enough. Whereas the pec minor and the levator scapulae seem to be muscles that become hyperactive in relation to shoulder pain. With respect to the upper trapezius and the rhomboids, there is less consensus. Some studies stating that the upper trap and the rhomboids are hyperactive in relation to shoulder pain, whereas other studies show decreased activity or weakness. Now, as we know, some of these levels of hypo and hyperactivity are based on assumptions, but for some we also have some scientific background. For instance, with respect to the lower trapezius, we know that this muscle is very prone to inhibition in case of shoulder pain, because many studies have shown decreased activity, slow activity, or a change in the balance ratio between the lower trapezius and other scapular muscles. In some recent studies from our research group, we also found that people with shoulder pain, impingement-related chronic shoulder pain, they have hyperactivity in the pec minor during activity in the scapular plane. So when they elevate their arm compared to a normal group, they showed more activity in the pec minor muscle, which might compromise scapular position and scapular movement patterns. So in view of that, one of the criteria that we can use during the exercise choice is choosing an exercise focusing on relevant muscle balance ratios in which we want to inhibit the hyperactive muscle with simultaneous activation of the hypoactive of weak muscle. So when we look into that, and it was recently published in a book that I was happy to co-author a chapter with Laurie here, we can actually define a list with hyperactive muscles, combine them with a list with possible hypoactive muscles, and then we end up with clinically relevant balance ratios, when on the top the muscle we want to inhibit, and on the bottom the muscle we want to activate. And fortunately, the past few years, we can make up a list with exercises that are good to restore that balance, and these results are all based on EMG studies, analyzes muscle activity levels during exercises. Now, in view of the timing, of course, it's not possible to go into detail into all these exercises, but I want to focus on some highlights, some tendencies, and some advices that we can take up to the clinic. And these are all based on the EMG studies that we have published already, but also on some EMG studies that we just recently received results from, meaning last few weeks. So I have some message, or at least some advice that I would send out to the clinician. The first message is the following. If you want to increase activity in the middle trapezius and the lower trapezius, often seem to be weak in patients with shoulder pain, we have to add an external rotation component to the exercise. And when we go from the left to the right on our screen, we can perform, for instance, external rotation diagonal patterns or main external rotation exercises. We know that this activates the middle and the lower trap. But you can also, like in the middle movie, add some external rotation during elevation exercises, because we also have shown that it increases activity in middle and lower trap. And very recently, not published yet, we also performed the so-called WV exercise in a prone position, and also found that when you add external rotation, you increase the levels of activity in these targeted muscles. The second message is about the serratus anterior, and it's actually a combination of several studies that we performed. Combining the results of these studies, it seems that if you want to target the serratus anterior, we should prefer elevation exercises rather over isolated protraction exercises. As you can see on the left side, the wall slide compared to some isolated exercises showed more activity in the serratus, and also forward flexion in the several planes was showing higher activity compared to protraction in the horizontal plane. The third message is about the upper trapezius. If you want to decrease upper trapezius activity because your patient has some hyperactivity in that muscle, we can either add external rotation again, or by preference perform the exercise in a lying position, because we showed in several studies that when the patient is lying down and his head is resting, we have decreased activity in the upper trapezius. In the patients who have hyperactive pec minor activity, it seems that we should not work too much in a closed chain, but rather work in an open chain, because these two exercises you see on the screen were analyzed in the same study, and we indeed could show that when you close the chain, there was an increase of pec minor activity, but when you opened it, adding some external rotation, we decreased activity in the pec minor. The final message is about the levator scapulae. This is also a muscle that, from a clinical perspective, very often has too much activity during daily life. In two studies we performed on that level, we found that if you work overhead or in a closed chain, then you decrease the activity of the levator scapulae without decreasing too much upper trapezius activity, which might be necessary in this population. So from the left to the right, we performed 3 exercises with decreased activity in the levator scapulae, which is what we call the overhead retraction. In the middle, the overhead shrugging movements, and on the right side, again, the wall slides. So the big challenge of the future might be, what is the role of the kinetic chain? We all tend to use a lot of kinetic chain exercises because it's flashy, because we assume it's more functional, but the question is it like that? Well, for now, we don't have a lot of information, and they are a little bit with conflicting results, so I would just want to go over some preliminary results on that level. We know from a recent paper from Brazil that conscious contraction from the abdominal core muscles increases serratus anterior activity during low load exercises. So the exercises in this study were isometric and low load, and they increased activity in the serratus when there was a conscious contraction in the core muscles. In another recent study that is not published yet, but we are working on the paper, we compared unstable versus stable conditions for the trunk. And when you make an unstable condition for the trunk in these exercises, it was challenging core stability. And we also found increased activity of the serratus anterior. So it seems that the core muscles are really related to serratus anterior activity. Another thing we tried to do was look at the influence of trunk rotations and lower extremity movements during diagonal external rotation exercises. So we did the external rotation exercise you saw earlier on the screen, and we added some squatting movements, lunge movements, trunk rotations, but apparently, according to our study, these changes did not positively change scapular muscle activity levels. And then finally, it's only a minor change, but we also try to change something in the distal link. So we asked the patient or the subject to perform an exercise with a fist, so grasping the TheraBand, or with the hands open. And we found that not making a fist increases activity in the middle and the lower trapezius. So as you can see, there is still some conflicting results and a lot of work to do. But as a take-home message, I would like to repeat the main things that we did found based on the studies that I just presented. You want to train middle and lower trapezius? Add external rotation. You want to focus on the serratus anterior? Perform elevation exercises. You want to decrease activity in an hyperactive upper trapezius? Perform external rotation again, or let the head rest. You want to decrease activity in the pec minor? Switch to open chain exercises. You want to decrease activity in the levator scapulae, work overhead, or in a closed chain. So thank you very much. So now we'll be happy to present Gisela for the next speech about proprioception.
Thanks. Tēnā koutou, tēnā koutou katoa. Warm Pacific Island greetings. And it's always a privilege to me to be back in what I consider to be my hometown in Cape Town. It's as stunning as ever. So I'm going to talk about whether impaired proprioception might be a contributing factor towards chronic rotator cuff-related pain. We all know the simplistic definitions of proprioception as perception of joint movement and positioning in space in the absence of visual feedback. That comes from Sherrington more than 100 years ago. More expanded definition is the afferent information from the peripheral segments contributing towards joint stability, postural control, balance, and motor control. Now, arguably, Scott Leopard was one of the first people who applied the model of proprioception specifically to the shoulder, and he focused on post-dislocations. And I think you all know this concept, that capsular ligamentous injury leads to proprioceptive deficit, according to that model, and which then influences the neuromuscular control. And together with the mechanical instability, that would lead to functional instability and thereby going into a vicious cycle. Now, when we assess proprioception, clinically, there are quite a few downloadable apps nowadays that you can use. In the laboratory, we normally use a dynamometer. And there are many different types of variables we can assess, but the two most common ones in terms of research are the joint repositioning and the movement, a sense of movement. And the repositioning can be active or passive, and in that case, the person normally has a blindfold on and is asked to reproduce the position that they'd felt a few seconds earlier. For threshold to detect passive movement or the motion sense, the person normally also has earmuffs on to decrease auditory signals, and also their arm is in a pneumatic sleeve to decrease tactile sensations or pressure sensations. And in that case, the lever arm of the dynamometer starts to rotate very slowly, normally less than 5 degrees per second, and the person is asked to press a trigger as soon as they sense the motion. Now, what happens in people with shoulder pain? Can proprioceptive variables differentiate people with shoulder pain from those from controls? We conducted a systematic review a few years ago with the help of 2 students from Umeå University who were coming to Otago, Charlotte Fur and Linnea Gustafsson. And here are just 2 forest plots from the study. Now, don't worry about the detail. These are all different movements that were assessed in studies in terms of active joint position sense. But what you see right at the bottom in the pooled mean difference is that the controls, the uninjured controls, did have slightly more, or there was a tendency for them to have higher accuracy of movement compared to those with shoulder pain. But that pooled mean was not statistically significant. So at the moment, with active joint position sense, there's no clear or consistent difference in proprioception when you compare those two groups. But if you compare the injured side to the uninjured side of the injured participants for passive joint position sense, there was a clear, significant difference in terms of the uninjured side being more accurate. So in other words, the injured side did have decreased proprioception, if you want to call it like that, for that variable. So these are results of people with post-traumatic linear humeral instability, but what was rotator cuff tears or rotator cuff-related pain? There weren't enough studies to pool the data, but this is one of the studies that used joint position sense in female assembly line workers, so people working with their upper limbs all day. They first compared a group of asymptomatic workers, no shoulder pain, to non-working controls. And this is a forest plot I drew of their results. And here you have the active internal and external position sense first, and then the passive internal and external rotation. Sorry. And what I found, or when you pull the data of all those 4 tests together, the non-worker controls have better proprioception than the asymptomatic workers. So it might be that moving the arm all day repetitive over a period, that by itself might be decreasing our proprioception acuity. So is fatigue potentially a factor in proprioception? 2 studies that I found on acute fatigue on proprioception are these. This is the first one more than 20 years ago now, where they took healthy individuals and they did a fatigue protocol in a lab of internal external rotation, and they assessed motion sense. And here you see the white column is for the pre-fatigue state and the black for post-fatigue, for internal rotation motion sense and external rotation sense. And what the results show that with fatigue, there's increased thresholds. So the person has to move further before they sense the motion. So statistically significant decrease in proprioception with that acute fatigue. However, in a more recent study from University of Sydney, they found no significant difference between pre and post-fatigue baseball throws, and they got them to throw for 10 minutes. So they used a different fatiguing protocol. So unclear or inconsistent result of whether acute fatigue really influences our proprioceptive acuity or not. Quite interestingly, these authors also found no relationship between the proprioceptive variables and the performance tasks of throwing speed and accuracy. So there's still questions how important those proprioceptive variables that we can measure at the moment are for performance. So coming back to the study by Hike on joint position sense in the factory workers, when they compared workers with shoulder pain, rotator cuff-related pain, to asymptomatic workers, when I pulled that data, there was no significant difference between those 2 groups for joint position sense. But quite interestingly, for the active internal rotation, so this one over here, it seemed that for the patients with shoulder pain, they had enhanced acuity. So do they have better proprioception for that variables under those testing conditions? So that is a bit counterintuitive for us as clinicians. We conducted a series of experimental pain studies a few years ago. If you use an experimental pain study, that model allows you to explore influences of pain without any structural damage in the area. So we had young people, and we used the crossover design for the first set of the studies, and half the group were injected saline directly into the shoulder, which then causes subacromial pain for about 15 to 20 minutes. The other group were in the control group first, and they crossed over for the second set of tasks. And we did a battery of tasks, including throwing accuracy, internal and external isometric muscle strength, and then elevation tasks for EMG and scapular control. Won't talk about those 2, just the upper first 2 conditions for this presentation. So the saline injection in that study caused pain about 5 out of 10 on a visual analog scale as an average, And here the red columns are for the control condition, the blue are for the pain, and for external and internal isometric muscle strength and for the throw, there was a very clear and significant difference or decrease in performance with the pain. They all dropped by about 20%. So that pain model was strong enough to have an effect on those performance measures. We then conducted another study on proprioception using a different design where all participants had a control group first, followed by the pain condition, and then a second control group. And we assessed passive joint motion sense, passive joint position sense, and motion sense. And for this one, for the joint position sense, the pain was 7 out of 10, so it was quite moderate, quite close to severe for some of the participants. And for motion sense, it had dropped down for 5. We found no significant difference between the conditions for position sense. So just having the pain in the previous studies was sufficient to decrease performance of muscle strength and throwing accuracy, but here we did not find a significant difference for the position sense. But for motion sense, in the pain condition, there was a significantly decrease in the threshold, which we would interpret as being better proprioception with pain. And in a sense, it started raising the question whether some variables of proprioception may actually be enhanced in the presence of pain and become part of fear avoidance or other more negative behaviors. So overall, the current assessments for shoulder proprioception produce unclear results in terms of differentiating groups with shoulder pain from controls. There aren't consistent findings in that. We also don't have enough information yet of the effect of fatigue or repetitive movement on proprioception, and also the association between proprioception and performance tasks is unclear. Now, coming back to the model by Leppard, I suggest that their model was focused mainly on the peripheral mechanisms, so what's happening in the muscle spindles or the Golgi tendon organs at the shoulder level. But I suggest we need to think more about how central mechanisms influence proprioception in addition to what is happening more peripheral. So could specific variables of proprioception potentially be enhanced in the presence of pain and lead to fear avoidance or contribute towards fear avoidance, and thereby potentially being part of the chronicity of rotator cuff symptoms? Or we also have to ask how central sensitization or smudging of the brain influences the outcomes of those tests. Now, in terms of the pathways, Leppard focused mainly on the afferent pathways, but we have to think about the central pathways as well. This is a brilliant figure from Anne and John Sebastian's study. They can answer all the questions later on. So a model that I quite like in this regard is from Laura Mimosi, just recently published in a dance journal. And you may know the model that our movement, our experience of pain is modulated, depends on neurotags or functional connections in the brain. So you have a neurotag for the movement, for dance, for throwing, for the work-related movement, another neurotag for protective mechanisms or for pain. But what we have to remember is that those neurotags are influenced by many different variables, and proprioception is just one of those. And the brain probably prioritizes what information they use, and if that is so, that huge variability, then when we test proprioception in an isolated way, we will get very different results. Reliability of the lab-based proprioception is actually quite high, but with patients from one day to the next, I suggest that these can change quite rapidly and may also depend on whether the brain is in high or low alert. Now, clinically, we use different concepts in our rehab. We may be prescribing exercise to improve proprioception, or think more in terms of sensory motor training, body image, motor control, scapular control. Quite often we focus mainly about what is happening in the shoulder when we prescribe those exercises, for example, strengthening the muscle tissue. But we should also at the same time think, what effects do our exercise also have on the brain or the central pathways? If we do that, then I think we will have a clearer indication of how everything works together and then leads to, towards chronicity of rotator cuff pain. So, in conclusion, there's no strong evidence yet as to how changes in proprioception contributes towards the chronicity of the rotator cuff pain. We need to consider that proprioception in some cases could potentially be enhanced in the presence of pain and thereby facilitate protective mechanisms. So maybe we need to think about decreasing the sensitivity of proprioception in some patients. We need to consider the central effects, not only the peripheral effects of our treatment on our patient, to really understand what is going on. So consider influence of interventions. It might be exercise prescription, manual therapy, or even pain education on what is happening in the brain besides what is happening in the shoulder itself. So I need to acknowledge my funders and also my collaborators, particularly Craig Bossinger, who's in University of East Tennessee in the States. Thank you. Now it's over to Philip Strath.
Okay, thank you. Thank you also for giving us the opportunity to share some thoughts on chronic shoulder pain with you all. And of course, Cape Town is the most beautiful city of the world, but Antwerp is the second most beautiful city of the world. And actually, as you can see here, our city symbol in the circle here is an overhead athlete. So if you're interested in the shoulder, and I can imagine you all are, you should come to Antwerp. It's our campus, but I'm not here to talk about that. I'm here to talk about central sensitization in relation to rotator cuff pain, chronic rotator cuff pain. So I will go with you through some questions, like first, why talk about central sensitization pain? Why talk of what is central sensitization pain? Does it even exist in shoulder pain patients? Can we detect it in clinical practice? And if we do, how should our treatment be different if our patient has a predominant central sensitization pain picture? Okay, so let's go to the first question. Why talk about central sensitization pain? Actually, Jean-Sébastien has started this session by explaining the differences between damage and pain and the possibilities of central nervous system to adapt to the presence of pain. So that was already a good introduction. So shoulder pain is of course a very prevalent thing, but that's not the only issue here. The big issue is that we have so many chronic shoulder pain patients. We have so many chronic shoulder pain patients, and like 40% still have shoulder complaints after 1 year. Many frozen shoulder patients will be in there, but also many chronic rotator cuff tendinopathy patients will be in this group, which is of course also a big economic cost to this group. So that's an issue, and many of these chronic pain patients, because that's what these chronic rotator cuff patients are, chronic pain patients, they show specific neuroplastic changes in the peripheral and central nervous system. So neuroplasticity is like planning a better response to a stimulus, and in this case it's pain, so it's a bit a bizarre action, so you try to plan a better response to pain. So neuroplasticity is, in this case, it's not about habituation. You habituate like when you wear a shirt after 15 minutes, you don't remember, you don't know that you're wearing a shirt. But if you sensitize to it, you will start feeling pain. So in this case, in case of pain, in case of prolonged strong stimulation, sensitization is an option. So you get functional chemical changes, more receptor, ion channels will be open longer, some brain regions will evolve, and so on. The net result of this is that the signal transduction from the nociception towards the brain will start being more efficient. So if you can see this on this graph, for instance, here you have an innoxious stimulus which goes to a noxious stimulus, and the more you go to the noxious stimulus, the more a pain sensation will occur. That's a normal situation, but in case of a centrally or peripherally sensitized patient, this graph will shift to the left. For instance, in case of an innoxious stimulus, you will easier get a pain sensation. And even, and that's the allodynia here, even in case of an innoxious stimulus, there is already a pain sensation. That's present in patients with central sensitization pain. So you get on the left here, in case of a normal sensation, you got pain here. Pain goes through the nociceptors and it gives you a pain sensation. And you got touch. Touch goes through the low threshold mechanoreceptors and gives you a touch sensation. But in case of central sensitization, you have here your nociception. It goes to your hyperalgesia. So this means that a small nociception, a small touch, a small pinch can give a very large pain sensation. But even here, underneath, here when you have touch, this touch can lead to a pain sensation. A touch is not a noxious stimulus, but it can still lead to allodynia, to a pain sensation. Okay. Does this central sensitization pain exist in shoulder pain patients? What's the evidence here? We have a few systematic reviews, few recent systematic reviews focusing on central sensitization pain in shoulder pain patients. For instance, here at the role of central sensitization in shoulder pain, a systematic review we did, and I will go with you immediately to the conclusions. They said, well, there is an emerging role for central sensitization in unilateral shoulder pain. Another one from John Borstad, not so long ago, 2015, they concluded evidence for its presence in those with shoulder pain is significant. And then finally we did one in 2017, not so long ago, and we concluded that there was still some additional research required. Apparently our chronic shoulder pain patients, there is such a variety within that group that we can probably say that there will be some subgroups within the chronic shoulder pain patients that will have central sensitization pain, but not all. Chronic shoulder pain does not mean you're centrally sensitized, but there will probably be a factor or a subgroup within this population which is maybe responsible for the low outcome of several treatment options. Okay, now we will transfer this evidence towards clinical practice. So first we need to detect those of having predominant central sensitization pain, and afterwards when we have detected, we need to know what should we do in case of we have a patient that we think of having a predominant central sensitization. Can we detect central sensitization in your clinical practice? Yes, we can. A few years ago, a pain physician, the Pain Emotional Research Group, had a nice overview and created an algorithm on how to detect central sensitization pain in a clinical practice. So here's this algorithm, which started with, of course, musculoskeletal pain. You first exclude neuropathic pain, because then you will have a predominant neuropathic pain syndrome. And then you go further to a disproportionate pain experience. If your patient has a disproportionate pain experience, that's a chief element of central sensitization. If they don't, there is no central sensitization. If they do, you will look at the diffuse pain distribution. If the pain is very localized and they can put their finger on it and say, well, here's the pain and there's no pain never around my body, only at this point, well, there's not something that's usually seen in patients with central sensitization. Patients with central sensitization have more widespread pain. Okay, we go further and we have a central sensitization inventory score, which is actually a sort of questionnaire, and based on the team that discussed this questionnaire and the scores you need to achieve on that questionnaire, say, well, if you have a score above 40, well, that's something that shows that your patient may be having a predominant central sensitization pain. Okay, so you can detect central sensitization pain in clinical practice. Next question is, if you see that in your patient, how should your treatment be different from a patient that has not got a predominant central sensitization? First, you have to see two groups. It's a paper published by my colleague Mira Meus in Pain Clinical Update 2016. If you have two groups of patients, you have the joint pain, the chronic joint pain without dominant central sensitization here, and you have the chronic joint pain dominated by central sensitization. The funny thing is, well, actually not so funny, but actually very relevant, the thing is, both groups are having a benefit from neuroscience pain education. Both groups. You don't have to be central sensitized to benefit from pain education. Also, those without dominant central sensitization can benefit from pain education. So first, they suggested pain neuroscience education, and we know that education works. We reconceptualize pain, we explain pain. We know that patients can understand pain, their catastrophizing ideas will be reduced, and we will reduce threat. We know that education works in chronic fatigue syndrome, in fibromyalgia, chronic whiplash-associated disorders, and also in low back pain. Next step, in case of a non-dominant pattern, so this is the left side here, the authors suggested a graded a graded exercise therapy. So you're actually giving your exercise a graded program. In case of a dominated image of central sensitization, they suggest we have two different groups. You have persisters who keep on going, and when they have pain, they just stop, and when the pain is reduced, they will start again. And then you have avoiders. They just avoid each type of movement because movement will create damage in their eyes. So in both groups, we need to prime our patients. We need to be clear and we need to educate them. Okay, we will start with a program. For instance, in avoiders, there is maybe a need for graded exposure, whereas in persisters, you will need some sort of pacing strategies from, okay, let's divide your intensity of your program into small pieces and try to get a line in that without having the peaks in your exposure. And then afterwards, if you have primed your patients, it is suggested by these authors to start going from a pain contingent treatment towards a time contingent treatment. And the left thing here on the left side is quite interesting. It's actually a proposal for some sort of type of exercise. They propose more generally specific exercises in the first phase of a patient with a very high pain sensation, because we know that if you add general fitness, for instance, in your program, that this has a very good pain-reducing effect. And if your patient with chronic shoulder pain has a pain-reducing effect of treatment, then this will, as a good thing on priming your patient that exercise is not per definition harmful. If your patient starts, for instance, with a painful exercise, well, they say, oh, it hurts, that's something I can't do, that's something I won't do. So if you start with some general exercises and then afterwards try to build up your specific exercises, this is a proposed exercise program for your chronic shoulder pain patients, so both dominated by central sensitization and not dominated by central sensitization. A last one, maybe, manual therapy. I will not go into manual therapy in this session too much, but we have a nice systematic review of that. Manual therapy and its effects on pressure pain thresholds, which is a way of measuring the pain in your patients and the way the patients cope with pain. And their conclusion was that there was actually a moderate analgesic effect of manual therapy on pressure pain thresholds in patients with different forms of musculoskeletal disorders. The effects were on the pressure pain thresholds at the site of injury, not so much widespread. So they said, okay, there is maybe a pain-reducing effect at the site of injury, not so much towards other regions of the body. There is a little difficulty here with manual therapy in case of central sensitization, because your patient with central sensitization has a very strong picture of having a structural damage which causes his or her pain. And you just did your pain education explaining that's not always the case, but if you then start with grabbing the shoulder and your treatment is focused by only, for instance, mobilizations or whatsoever, then the patient might start thinking, oh, so it is the shoulder, it's not something else. So you have to be careful, you have to explain why you perform some sort of manual therapy, you have to explain that maybe you're performing some mobilization exercises which not really related to the pain and so on. So you need to conceptualize your manual therapy techniques with these patients, or otherwise you will enforce their biomechanical thinking. So if you question at the end of the session, is it the brain, is it the central nervous system, or is it the shoulder? It's just two wings of the same bird. You need to focus on that in your patient with shoulder problems, independent of central sensitization. Thank you.
Okay, so thank you all for your nice presentations. So now it's time for questions. So we have enough time for several questions or discussion about the shoulder. So please feel free to go to the mic, say your name and where you're from. You can ask specific question to one of the presenter, or you can just ask a general question that will be answered by all of them.
I'm Paula from Brazil. Thanks for the presentation. Nice to meet you. They were all very good. I have had some discussion with Laurie already, but I'd like to know the opinion of others, and you can also say a little bit more if you want, Laurie. It's not that I'm excluding you. But most of the studies, they show that people with shoulder pain, they improve if you do the exercise for the scapula, but we don't see changes in kinematics. Let's pretend to have the most perfect device to measure scapular kinematics, okay? So what do you think we are doing wrong? Can we really change scapular kinematics? This is one question. Can I have the second one? And the second one is, I'd like to know, I think that's more for Philip, how can we identify a person with central sensitization? And what do you think would be the best approach for these people? Only the education on pain, this modern neuroscience, or should also apply the exercise for them?
Thank you very much, Paula, for this nice question. Indeed, we have a problem when we look at outcome measures and the outcome of scapula-focused treatment programs, because we do know that patients get better, but we cannot show that their scapular kinematics change. I don't think it's about the methods, it's about the fact that probably it doesn't change. And I also believe that one of the reasons why we cannot really focus on only the kinematics, which is a very laboratory setting, the thing is when we do exercises so-called for the scapula, we move the shoulder and we do general exercises. So whatever we do, the local approach for the shoulder is present in the exercise, plus the scapula, plus the global body. So it's very hard to distinguish between a so-called scapula-focused program and another one. So maybe that might be the reason why we cannot also not focus on the outcome on that level. Having said that, I think that from a clinical perspective, we want to have our patients doing exercises of which believe we target the right muscles. And we don't want to even more activate the ones that are known to be hyperactive. So when we select exercises that are, by the way, the exercises are selected on studies on healthy people, so we should acknowledge that as a limitation, that we did not do it on patients, but it's on healthy people. The main thing is that we don't want to increase their dysfunction. And once again, I think that you cannot distinguish between a specific focus on an exercise because they're always too much combined to have one outcome out of it. You want to add something, Laurie?
Yeah, maybe if I can also add something on the scapula. As Anne said, it's very difficult to make a conclusion about cause-consequence and about whether or not the scapula has been the reason for improvement or not. But actually, if you also think about when you search for a very specific exercise, if you want to focus the scapula, then actually it's that exercise that also is a very excellent rotator cuff tendinopathy exercise. For instance, if you want to focus on challenging the scapula on movement, and you want to stabilize the scapula, you actually need, per definition, to challenge the cuff. You need to challenge the cuff, otherwise the scapula will not be challenged. You need to load the cuff to challenge the scapula in many exercises. So that's probably also the reason why very good scapular exercises are also very good rotator cuff exercises. patient improves, and afterwards it's difficult to say, was it the scapula or was it your tendon loading that did the job? But the most important thing is if scapulothoracic exercises are included in your patient, and that your patient benefits from it, whether or not it was a scapula or the tendon that's got the improvement. Something else? Yeah. Then the other one on central sensitization. Yeah, I think we can really define these patients. It's not black and white. Sometimes it's difficult. Many of our patients with central sensitization have, for instance, you can of course use the flow chart I presented to define whether or not your patient has a predominant image of central sensitization pain. But many of these patients have some classic symptoms of sensitization that you can already hear in your anamnesis. These are the patients who come in your practice during winter with sunglasses, or they're wearing this heated underwear in summer, and there are some strange patterns in these patients. So you will already have a feeling, okay, this might be a patient that has some neuroplastic changes, and then you can check it with, for instance, these algorithms. And if you assume that your patient might benefit from a treatment that is focused on central sensitization, then I think there are several options, like for instance pain education. But pain education, we know that it works, but it's not the only thing. You shouldn't stop your treatment after pain education. General fitness, graded exercises are, I definitely believe that these are the keys to a good rehabilitation also in these patients. But the only important thing here is that your patient will, if they get pain during exercise and they still believe that exercise is, or pain is a provoker of damage, then you have a problem. So you need to get out of that circle of thinking, and then you will probably have more benefit from a good graded exercise treatment program.
Yeah, go ahead.
Masharo. My name is Masharo Youssef from Tel Aviv University. First, I would like to really compliment on this amazing session. I think that for the first time I've heard that so many aspects concerning the shoulder is coming all together. So it's really nice session, and thank you very much for that. The second thing is that I want to emphasize the fact that it's either a whole or nothing. I mean, it's either we treat everything together in order to improve if it's the shoulder pain, if it's a central, or if it's a peripheral. It's a whole or nothing concept that when we treat the shoulder pain should be taken care of. And what you did here is to emphasize this aspect more than anything else. So treat everything, not just one thing. The third thing that I want to emphasize is the fact that we're talking about, if we talk about the scapula, the glenohumeral, we're talking about the spine, and the spine is the thoracic. So we need to emphasize as much. I know that we can't do everything in one session, but we need to emphasize the thorax, the position of the thorax, the effect of the thorax on the shoulder. Even when we want to diagnose shoulder pain, we just finished a study concerning the effect of the thoracic position on the shoulder test, and we found no effect on immediate effect when it's an acute shoulder. But I'm sure that with the chronic stage of that, we really need to take this into consideration. That's because we wanted to put all together the whole or nothing. Thank you very much for the session.
Just a comment about the last thing you made a comment about for the thoracic spine. I think there's likely a treatment threshold for people who have or impairments of the thoracic spine that likely need treatment, meaning we blankly treat everyone, the thoracic spine, be it manipulation, be it posture correction, but everyone doesn't necessarily need that, and this may be why we get washout effects when we look at collapsing everyone together, taking anybody with shoulder pain or even a single diagnosis, give them all that treatment, and we don't see an effect, for example, with manual therapy or posture.
I will comment on that, but just I think that's really because we're talking about discussion here about the subject. When you do manual therapy, it's not about mobilizing the joint also, it's also soft tissue. It's also about, really re-educating the soft tissue interaction with the scapula and the shoulder. So when I say treating the thorax, I'm not saying treating the joint, but the whole issue. So.
Yeah, there.
Hello, my name is João. I'm from Brazil. I want to have a question for Ancus. And first of all, I want to congrats you for the presentation. It was amazing. And I want to know if thinking in scapular dyskinesia, like in these exercises that you showed for us, if you have some approach, additional approach with myofascial release, thinking in hyperactivation of pectoralis minor, or just the activation about with the exercise for the other muscles, the muscles that don't work like him, you can just decrease this hyperactivation and achieve the scapular like what you want with these patients.
So if I understand it well, your question perfectly matches with the last comment. It's about soft tissue techniques besides exercises. Is that your question?
Yeah.
Yeah.
If you use it or you
yes,
think
of
it's
course.
not necessary.
We have several heads. We have the head of the researcher and the head of the clinician. I think as a clinician it's very important to look at the surrounding soft tissue and to work on inhibition of muscles by any means that you prefer in combination with the right exercise, because soft tissue mobilization is very important not only on the level of the shoulder, also on the level of the scapular muscles and the thoracic spine. But as far as I know, it's very hard to standardize these techniques, to transfer them to a research design, because then you have to, an exercise is easier. You can do the exercise, a set of repetitions, 3 times 10, whatever. It's very hard to standardize soft tissue techniques. And we also, in the clinic, we implement both sides. But when we want to do a study, it's very often necessary to have a very clear protocol for your treatment in which soft tissue techniques can hardly be standardized. I don't know if you agree with me, Laurie, but as a clinician, I believe it's very important to look at tension of muscles besides trying to inhibit it during exercises.
Thank you.
David?
I'm David from Denmark.
But I have one comment to make about the comment about scapular dyskinesis. We didn't talk about this today, but I have to throw that in here. I think when we consider the scapula moving abnormally and we look at it visually and we say, there must be something wrong, the evidence is really starting to point strongly in the direction of seeing an abnormal moving scapula visually likely doesn't mean much with respect to driving treatment decision making, because lots of people without shoulder pain also have funny moving scapulas. And so unless I can move that scapula and they feel better with that movement, and then use soft tissue muscle training techniques to improve then the movement of the scapula, I think if you can't perturbate it and change their symptoms, then I'm not sure that a funny moving scapula means anything. Sorry, I had to throw that.
Yes, like I said, I'm David from Denmark. I have a question for the whole panel. Actually, thank you first of all for great talks and for making a symposium like this. I would like to, if you could comment a bit of prognostic values of the things you're talking about. How does this fit in with the scapula, the tendinopathy, the central sensitization, the proprioceptive? What do we know about the prognostic value of these things compared to other prognostic factors like duration of pain, psychosocial variables? Could you comment on that?
I don't think we know much about these factors. I'll talk about scapular dyskinesis. I think we know that it likely alone doesn't mean much. And so prognostically, if someone has dyskinesis, from a prevalence standpoint, it likely doesn't mean much with respect to diagnosis. And so prognostically, tendon, if we see the tendon looks abnormal upon imaging, we likely prognostically know the tendon isn't going to change, reverse, but whether or not that means anything with respect to they'll recover from that, I don't think we know much about that.
In sports, there was some studies showing that if you combine scapular dyskinesis with a sudden increase in the general load of training, then you have an increased risk for injury, but not only scapular dyskinesis. So I really think that the combination of symptom reduction through your manual helping the scapula combined with some other factors like increasing load in sports is much more important than looking at one isolating prognostic factor. But Philippe, you did some prognostic studies?
Yeah, I've stripes done also, haven't you?
Yeah. Doing prognostic studies is quite difficult. Of course, definitely in also around the shoulder, you need several healthy subjects and wait and hope they get shoulder injuries. So that's a strange way of doing research. But we saw that in most of the studies, the results for predicting shoulder pain based on scapular dyskinesis, they demonstrated that scapula was not able to predict shoulder pain. There are a few that do. I think maybe 2 the last 5 years that show that scapular dyskinesis can predict shoulder pain, but these are different from the other studies in the sense that they focus on top-level athletes, whereas if we focus on recreational or high school level, then there is no predictive value. But maybe in top-level athletes, so you can maybe suggest that the scapula might be a small factor within the kinetic chain, and if that small factor deviates, then it's not so much an issue in recreational athletes, but it might be an issue in top-level athletes. But that's just a suggestion based on some studies. Maybe when I'm talking now, I can say something about central sensitization and the prognostic factors. Actually, we're happy to see that we're creating a little evidence on the presence of central sensitization in our chronic shoulder pain patients. And that's the first step, and we actually don't have anything yet on the prognosis on central sensitization towards development, for instance, on shoulder pain. So that's really just the starting now. Yeah.
I'll add it, Penny's words here. It's that shoulder pain continues to remain absolutely multifactorial, and from one person to the next, the variability of those different factors will be different. So if you look at them as a group, it is very difficult to find what consistently will predict chronicity. So we need to consider that the multifactorial approach is necessary and will also change from day to day and from patient to patient.
And that's why I think I'm missing a link here. There's the whole society around the shoulder patients. There's psychological factors which we haven't really touched upon. And I think maybe we have to look for, like in other areas of the body, like low back pain, that we know that clinical factors are really not that predictive of outcomes in patients with the MSK.
We're done. We don't have any time left. I even prepare a conclusion that we won't use. So thank you for your participation, and thank you for attending. Thanks to the 4 presenters with their excellent presentation. So see you.